and a very, very important topic as well. So we really appreciate all of you coming. And I'm sure, as usual, quite a few will still join us in the next couple of minutes as everybody get away from the patients and their workstations to get here. So before I introduce our speaker for the day, I would just like to remind you all that this session is hosted by iEcho and the Gastro Foundation in association with Project Echo at the University of New Mexico. The sessions are held every Wednesday, but most of them are actually either hepatology or gastroenterological, scopes and stuff like that. But every second month or every 6 to 8 weeks, we get a slot for patient blood management. And it's become a very popular slot, and we're very excited that so many people are supporting it and coming to join us every time. So the exciting thing today is that we have Professor Axel Hofmann with us in the room. Now, if I look at the list of people in the audience, I think that many of the people here today have not met him before. I see some that I think have been in the room with him before, but for many of you, Prof. Hofmann will not be known, but you are looking at arguably the leader in the world in patient blood management. So Prof. Hofmann has carry many hats. He's a professor at both the University of Western Australia, but also in Switzerland, in Zurich. He's from Austria, and he's also the person that leads the International Foundation for Patient Blood Management. He's incredibly widely published on the topic, and he's also the person who led the largest study ever on patient blood management, which was done in Western Australia, where they looked at the whole of Western Australia. And I don't know if Prof. Hofmann, if you will speak to this particular study in this talk today, but they basically established the fact that this is a concept that falls within the quadrant where you improve patient outcomes while saving money. And it's something that every doctor, doesn't matter what specialty, can in one or another way be part of. And that's what makes this really interesting as a topic for all of us. So, Prof. Hofmann will today speak about something that we've been waiting for, I think, for many years, but at least the last 4 or 5 years, since I had the privilege of being invited by him to be part of a working group way back where we met in Perth. And he really led the way with a group of global experts, of more than 80 global experts, to put together an implementation guide for patient blood management in the world on the request of the World Health Organization. We had hoped that it would be published, I think, a year or a year and a half ago already, but it was at last published quite recently. And today is the first time that we have the opportunity on this group and in South Africa, and actually in Africa, I think, to hear about this in detail. So before I hand over to you, Axel, I just want to say again, thank you for the incredible support you've been to patient blood management globally, but in particular to South Africa. Axel has helped us write a number of papers as well, where we could also put a South African perspective on the table and the opportunity we have. Thank you for what you're doing. Thank you for inspiring many of us as individuals. Thank you for being a good friend. And it's great to have you here today. The closing at the end of the meeting and the discussion will be led by Dr. Yaglin Naidu, one of our own local champions of patient blood management, hematologist from Pietermaritzburg, who won the Minister of Health's prize in KwaZulu-Natal for his efforts in this area. So we're very grateful for your contribution today as well. Yaglin, we're making a tag team here. And with that, Axel, I'm happy to hand over to you.
Thank you, dear Vernon. Thank you for these really nice words. the one that I like the most is that you telling everyone that we are good friends, and indeed we are. It's always a pleasure to be with you, to work with you, to discuss with you these and other topics. So thank you for having me, and thank you to G-Echo for inviting me. So let me upload my slides and start the presentation. And by the way, I will not talk about the Australian study because we might do it. We might cover this in the discussion part. So I've been asked to cover the topic, the WHO's patient blood management implementation guidance. And before I start, this is my disclaimer. I receive fees, honoraria, and travel for consulting and lecturing from governmental and public institutions, professional societies, and NGOs, blood services, and sometimes from the industry. However, the WHO project was pro bono with no industry support. What I want you to go home with tonight or today after the presentation is this. It looks a bit cryptic now, but at the end you will fully understand what it means. 3P8 3E is the acronym that I want you to carry with you from now on until the end of your medical career. So, the introduction, we want to talk about this document, Guidance on Implementing Patient Blood Management to Improve Global Blood Health Status. Who are the intended audiences for this guidance document? Well, it's health ministers and senior staff of health departments, chief medical officers, health commissioners, directors of health, members of health councils, heads of regulatory bodies on one hand side, executives of health insurance systems, both private and public, and also health economists. On the other side, it is this multi-professional group of surgeons, physicians, quality and safety managers, hospital administrators, data collection, benchmarking, reporting experts, medical support groups, also laboratory medicine specialists, transfusion medicine specialists, patient representatives or advocacies, medical legal experts, ethicists, and in the middle, PBM implementation experts. So it's basically the whole universe of healthcare. And you might think this is a bit exaggerated, but you will see it's probably not. Um, the document also says before you read it, make the best use of it by familiarize yourself with another document, which is called the WHO Policy Brief, The Urgent Need to Implement Patient Blood Management, that has been produced in 2021. Meanwhile, it is translated in three more of the official WHO languages and through the African office of the WHO also into Portuguese. And in that document, there's many very important statements, but one I'd like to just recap, but headed by the question, why is there an urgent need for PBM? Because there might be many areas in medicine that could claim urgency, but why is it that this is of a real urgency? Well, there's two reasons, or three. Number one, it's the exceptional scope and magnitude of the unmet need to manage and preserve a patient's own blood. We look at least 2.9 billion individuals that are either anemic or suffer from micronutrient deficiencies, mainly iron deficiency. And there's an other 600 plus million individuals, slightly overlapping with the first group, having chronic or acute blood loss and or bleeding disorders. And so we can say that blood is probably the most neglected organ. And the other reason is the aging society, with the likelihood that this problem here these big numbers will further increase. What you see here on the bottom right-hand side is the global population structure in the year 2017. Now, 75 years from now, this is the shape, the expected shape of the population structure, which means that the number of individuals 80 years and older will increase from 141 to about 900 million individuals. And we know this is the biggest problem for healthcare, not only healthcare, for social security and many other aspects, for the ecology. But when it comes to the management of blood and the old paradigm that people think we can manage that with transfusion, we will fail because we cannot source the quantity of blood that is or that would be asked for if we continue with the old paradigm. And then PBM provides the rare opportunity, and Vernon mentioned that already in the introduction, you're getting more for less. And we are talking not millions, not hundreds of millions, we are talking billions of healthcare dollars. So the urgency for PBM is very nicely covered in that policy brief. The big question, however, is how do we implement this as a standard of care? And for this reason, we have this new guidance document. And one very simple first step to implement PBM is to use a language that connects with all audiences. And you've seen the audiences are very many. We are looking from a global perspective at potentially billions of beneficiaries of PBM. These people who suffer from these conditions with a few clusters, the women in the reproductive age and in maternity, the age population, children, but also the average person. We also look at about 40 million clinicians, according to ChatGPT estimates. We are looking at 165,000 hospitals, which most of them have very little knowledge of patient blood management still. We are looking at different challenges in 194 member states of the WHO. Some are very resource constrained. And finally, we are looking at a population that is insured by a health insurance monetary volume of $2.6 trillion. So all of them, many of them, are potential beneficiaries of PBM. Now, by changing the language, I want to do a very little excursion. We want to look at blood as an organ. The question is, do we recognize blood as the body's liquid organ? We might think of blood as the oxygen transport or the oxygen transport chain, the removal of CO2, but it's also the cradle of hemostasis, of immune function, of waste removal, of signal communication, of fluid homeostasis, of redox balance, hormone transport, pH and electrolyte regulation, thermoregulation, nutrient transport. Blood is a multitasking organ. And if you think about your blood from a patient perspective, while circulating through your tissues and organ, it collects and reveals your critical information on inflammation, infection, organ function, hormone levels, nutritional status, and cancer markers. It holds your antibody profiles, cytokine patterns, epigenetic signatures, and cell-free DNA. And these provide insights into your immune history, chronic disease burden, stress exposure, and latent pathologies. So your blood is your most comprehensive, accessible, and dynamic health database. And this is why your blood needs to be healthy. At the same time, we have to say, coming back to these first graphs, anemia, blood loss, and coagulopathy with bleeding represent one of the world's biggest but largely preventable yet greatly underestimated public health and health economic burdens. That is a statement that is so important to carry or to transport to other audiences. And from the epidemiological, safety, and clinical viewpoints, your own blood is the most neglected organ. And this is why we need PBM. The medical model to rectify this problem is patient blood management. And the therapeutic goal is improved blood health. So this is how we are trying to change the language around blood. And I recommend you to read that recent article published in Anesthesia and Analgesia, Blood Health, the Ultimate Aim of Patient Blood Management. So that's why we have in the title of the document both terms, PBM and blood health. And when you go into the first box of the many boxes in that document, it repeats the definition of PBM, a patient-centered, systematic, evidence-based approach to improve patient outcomes by managing and preserving a patient's own blood while promoting patient safety and empowerment. While blood health is the optimal function of individual elements of blood and their associated interactions with all other organs and organ systems, blood as an organ fits every criterion that defines an organ. No other organ system can survive without properly functioning blood. And uniquely, markers of the blood provide information on your health. And finally, it is, as I said already, the model that manages your blood. So now we come to the aid model and what drives it, after these basic statements. In public health, there are basically three drivers: the protection of health, the promotion of health, and the prevention of disease. And when you relate this to blood health instead of health, then overall, this concept improves the population health status. The evidence for this is overwhelming. So 3 Ps, we come to this cryptic formula. The 3 Ps, protection, promotion, and prevention, is one of the drivers from a public health perspective. Now we go to the bedside, we go to the clinical level. PBM is also good clinical practice. It includes diagnosis, therapy, and follow-up. And the evidence is burgeoning. The evidence is so strong that all stakeholders are really alerted to act to change practice. But not only the evidence, but also the economics are strong. Stakeholders see that they are enabled to act because PBM reduces the global burden of disease by millions of years lived with disability. It reduces transfusion-related costs by tens of billions of dollars. It decreases significant overall treatment costs by hundreds of billions of dollars, and it can enable the reallocation from funds to where we have a bigger bang for the dollar. Now, if we have we can tick box both evidence and economics. It's a no-brainer that stakeholders are ethically obliged to act. And this is what we call the 3 Es of PBM. Now, we have the government or public health level with the 3 Ps and the health organization level with the 3 Es. And we need to bring them together to manage this paradigm shift. And this is where the aid model comes into play. The first sequence here in the upper left quadrant is the preparation of the national or jurisdictional healthcare system for PBM. Followed, and this is where this first group of stakeholders need to find his or her place and read the phase A of the document in more detail. Once this is done, we come to the second part down here, the conducting of PBM pilot projects, one or many. And this is where the clinicians come into play and where they have to carefully study what is written under phase B in this document. And finally, when we have successful implementation of pilots, then we come to the rolling out of PBM on a national jurisdictional level. It's again the responsibility of mainly public health authorities to manage the upscaling. or the scaling up, sorry. So altogether, this is the aid model to implement it. And this is where we get to unlock the criticism of this. So let's have a closer look in the first phase of the aid model, which includes 8 major steps with sub-steps. Number 1 is the Ministry or Department of Health should adopt a PBM policy for its country or for the jurisdiction. And secondly, establish governance for PBM implementation. Health departments or ministries of health are expected to make the proactive and system-wide top-down implementation a national priority by fully exploiting the public health armamentarium. Again, because the challenge is so huge. And then with the governance, you implement or you institute a task force, a national task force for PBM. And the first thing the task force needs to do is anchor PBM within the WHO-aligned quality and safety framework of a nation. That somehow falls in place, it's almost serendipitous, that the European Union came out with a new regulation end of 2024. It's the regulation of the European Parliament and the Council on standards of quality and safety for substances of human origin, or SOHOs, abbreviated, which includes the use of blood and blood products. And this regulation, this is a new level because so far they had only a recommendation, but now the regulation obliges the 27 member states of the EU to make this part of their national legislation within the next 24 months. And Article 58 says substances of human entities shall, of human origin entities shall not apply preparations to recipients without proven benefit. And also, these preparations should not be given or applied unnecessarily. SOHO entities shall make optimal use of these products, including blood, taking into account therapeutic alternatives and following the most up-to-date guidelines as referred to in Article 59. And in this article, the Council says it may be deemed necessary to adopt additional implementing acts when the member states are not moving forward fast and effectively enough. So once this is anchored, the next thing is mandating PBM education for professionals and students. And we don't need to reinvent the wheel for the material for this education. What you see here is the Annex 5 of the document with a large number of peer-reviewed PBM-related guidances, consensus statements, and recommendations by specialty or clinical setting. And this covers perioperative medical intensive care, obstetrics, gynecology, neonatology, pediatrics, situations of massive hemorrhage, particularly in trauma and the ER, and other situations. Once the education is secured, the next is to empower the public on blood health. We have a lot of initiatives around the world to educate patients about gut health, about brain health, about heart health. And now the next one, again, at the backdrop of the huge size of the problem on blood health. Next step is to secure access to essential PBM medicines and devices. And if you look at the list of essential medicine of most countries, you can see that many of them are at the same time essential medicines for PBM. Then the allocation of resources for PBM, and I'm saying allocation in terms of better reallocation because PBM releases money and doesn't consume money. And then finally, the selection of the appropriate pilot projects. Now, let's go into that next field, the pilot projects. It all starts It's six major steps with, again, many sub-steps. But number one, it all starts with the healthcare organization-based PBM champions. What are champions? They are individuals who are dedicated to supporting, advocating for, and spearheading an implementation initiative, and who overcome resistance that may occur at the organizational level. They have an intrinsic interest to implement change and to use their position to motivate others. This is a snapshot of PBM champions, of real PBM champions in 2025, and I apologize for missing out on a few. So you see the world is continuously covered by those. So champions initiating and driving a PBM in a healthcare organization. Step number 9 with 3 sub-steps. They anticipate challenges of culture change, which can be sometimes very difficult. They make situational analysis before embarking on the implementation process in terms of what are the population that need it most in my institution, in my area, for instance. What data do I have to support this? And then they implement PBM through a validated implementation methodology. That's covering more the psychological part of it, and we will talk a moment about it a bit later. Once they have personally prepared themselves and initiated by talking to informally to colleagues, they prepare the implementation in the health organization. That's at a stage where the chief administrators are not even aware of what you're thinking and what you're planning. And once you have your act together, then you present to the senior management of your healthcare institution and ask for authorization of a pilot project. And that might include some budgetary analyses for your institution. And once you cross that very critical point, then you start the implementation of a PBM task force. And usually it is the champions that will become members of that task force. And the first thing is they start to create a PBM structure in their organization, which means, again, establishing a governance framework for the implementation. And the document gives you, and we don't have the time to go through this, that's why I'm asking you to familiarize yourself with the document that shows who has what responsibilities and authority, how are we organized, who takes the oversight, what are the policies and procedures. And then you create awareness through medical education across all clinical and sometimes non-clinical departments of your healthcare institution. And then you select metrics and key performance indicators and develop other collection and reporting systems. And here's the annex number 4 in the document, metrics for healthcare organization implementation and also post-implementation periods. That gives you the metric name, the rationale, the proposed identified definition, the primary source, might be surveys, might be hospital case mix data, might be lab information system data, and it shows you on to what does it relate, to structure, to process, to outcomes, and this is a long list, and it's a very practical list and also shows you how you can really source these data. And finally, you develop a communication strategy to empower both the public and patients on blood health. Once this is done, you look into the specific clinical processes that need to be implemented. And these might be, of course, clinical, and what's the region's main population with an increased incidence and prevalence of ID, anemia, blood loss, and coagulopathy with bleeding? Which of those are the most vulnerable populations? What will be the staff, space, and system to serve these populations? What specific evidence-based guidelines and protocols will we pick from the annex and applied? Who will screen what or for what and whom? Where will be the screening done? What screening methods? What's the best timing for screening, for instance, for ID and anemia? And a list of many, many more questions to be answered. And they are on pages 63 to 65 of the document. And then, of course, patient empowerment. We talk about patient empowerment, informed consent, and by now in most countries we do not even have a full information and education on transfusion risks, particularly on the indirect transfusion risks. And finally, you create continuum of care for specific population or disease group. Such a continuum in a very simplified version could be this one. This is for major elective surgery in urban high-income country regions. And it really gives you all the different time points where you have to implement some very PBM specific activities. But you can also, with the tool that with the information of the document, look at population like women at high risk of postpartum hemorrhage in a rural low-income region, restricted to a community obstetric facility managed by midwives or nurses, locally certified in PBM, supported by community health workers or lay health workers. And I know that in Africa, a lot of um, situations are where we don't have doctors, not even nurses. So this is just a template that shows you how you what are the continuum of care you could possibly implement, and that you can pick the information to populate this with meaningful information is all to be found in the new implementation guidance document. It has large toolkits. Toolkits are referred to as a collection of resources, guidelines, strategies, and interventions designed to address specific health issues, improve patient care, or enhance healthcare professional knowledge and skills. And here is one of the 6 toolkits. This one is the one for neonatology and pediatrics. It's grouped by anemia, iron deficiency, bloodless and bleeding coagulopathy, and it has strategies to enable infrastructure changes and adaptation and to provide specific clinical knowledge and skills to create the continuum of care. It has knowledge and skills to ensure patient empowerment, vigilance regarding nutritional and pharmacological interaction, treatment devices to be considered, and medicines, access to medicines as well, knowledge of their uses, interactions required, with the resource, with the references that need to be there. The document also shows you the organizational structure that under the governments you might run during the implementation period. And you see the most important workflows again here: PBM data, PBM education, PBM communication, and PBM processes. And this might be supported by the IT department, by the human resources department, or by the PR department, if available. And once you have implemented, you have then an organizational structure at the end of the implementation period and beyond, where you run it with a medical PBM director, a program director, nurse consultants. And you might even serve as a national reference center for others. But we shouldn't forget that with all of this, you always have enemies. Your biggest enemies is the culture. And the culture is mostly driven by ignorance, incompetence, and inertia. And this is why this document also has a little section on changing HCO's culture methodologically. And it refers to another circle in the aid that could be integrated in the aid model, which is called the Carter model of change. John Carter is probably the world leader in culture change and change management, based in his institute in Harvard. And he follows these 8 steps that can be applied in the aviation industry, in the insurance industry, in the manufacturing industry, but also in healthcare and also in patient blood management, because we have done this several times, my colleagues and I, for instance, in the already mentioned huge Western Australian PBM implementation program. And then we come to the last phase in a more detailed manner, the national rollout. Once the government sees, okay, we have 1, 2, 3, 5 very successful PBM pilots, then of course we want to upscale. And the first step is selecting the pilots that should serve as national reference centers. This is done by the National Implementation Task Force. Once they are selected, then a small number of important data points should be mandated, reported, and benchmarked across the nation. And for this, you also need to some degree, PBM IT experts. And then you start with the certification for PBM. For instance, in Mexico, which is one of the countries with the biggest advancement in PBM, we have already managed more than 6,000 physicians that ran through a PBM certification course. And based on the certification, you can also look for accreditation and auditing of HCO PBM programs. For instance, in the document under this point, in more detail, you find 16 PBM standards to audit and to monitor the evaluation of PBM structure, processes, and outcomes. And feel free to go to these and try to apply them wherever you can. And finally, last but not least, the government can also facilitate and fund PBM research and development because they will learn and they are learning that PBM is really very beneficial for the entire system. So as a summary, we come back. I told you I want you to go home with the 3PA, 3E on your forehead. And the document helps you to navigate smoothly through these 3 major phases and these total of 19 steps and about 53 sub-steps. It gives everyone, every stakeholder, his role, his niche to find his place and to contribute to the greater good, but also to make his job and job assignments more enjoyable. I'd like to end with this statement of Dr. Yukiko Nakatani, the Assistant Director General of the WHO, saying, with the implementation guidance, PBM should now become part of the public health agenda of all member states, ensuring that hundreds of millions of individuals can benefit from this very detailed but yet practical approach to improve their blood health status. And as always, also allows the reallocation of the limited funds to where they are most needed. So study the document. It has more than 200 pages. 13 are really essential to get the story up front. Use it and spread it. Make screenshots, make a photo of the QR code, and please spread the news wherever you can. So thank you for your attention.
Thank you, Prof. Very well presented talk. I learned quite a bit from you. It's amazing. Just a few questions. I don't see any in the chat box at the moment. When I was implementing our local PBM at the local hospital, Grace, it was difficult to get buy-in initially from consultants or heads of departments, especially when they use local guidelines, and those guidelines are not in keeping with what's practiced internationally. And we had a few episodes where we needed to get hospital management involved. So I guess it's a lot of work between hospital management, the people running the PBM in the local facility, as well as heads of department. Do you find that also a problem in other parts of the country, in the world?
Yeah, no, absolutely. Let me refer back to Western Australia, and I'll have the chance to mention that if the audience looks into the first document, the policy brief, the urgent need to implement patient management, in the center page, you have an infographic of the Western Australian experience. And that was, in fact, a study with more than 600,000 patients over 5 years, where we reduced blood utilization by about 40%. Although when we started, we had already the lowest transfusion rate in the Western world. So many skeptics felt that we cannot do any better, and we did a lot better. And at the same time, we saw the association of a 28% reduction in mortality, 21% reduction in hospital-acquired infection, 31% reduction in myocardial infarction and stroke, 15% reduction in hospital lengths of stay, or 70,000 stay days, plus a direct transfusion-related cost reduction of about 80 million US dollars, or Australian dollars, which were equal to US at the time. Now, you can imagine that starting such a project that encompasses 600,000 patients, you cannot start with a clinical guideline in your hand. And you cannot even start with 10 or 12 departments behind you. This is why that there are some programs, where we have little islands within an institution, and sometimes you have even a whole institution that does it well, but is lacking sufficient support, is lacking the devices, the medicines, the staff, or whatever. So what you has or had as an experience is very common, and this is why we say with this, or we try to make clear with this new document, that with PBM we put something on the map where we had a blind spot for decades, right? Blood is the most neglected organ. This is not just an improvement of a field of medicine. This is the establishing of a new field. And therefore, it is a huge systemic change. And therefore, I was starting in my presentation with the many stakeholders and stakeholder groups that we need to address. The beauty, however, is that what looks like a lot of work, and is a lot of work, at the end makes life much easier because you get more for less. One of your friends and colleagues who was part of our guidelines development effort was Freddie Kabambi from the Nelson Mandela Academic Center, head of anesthesiology. And he said to me, Axel, in the first year when I was implementing PBM across the institution with a tremendous personal effort and passion, he said, I was saving the equivalent of the annual cost of five junior doctors, and he took the money and hired them, right? So it's a nice little experience. No, it's not that little. It's a big experience. So what you need is the involvement of the whole institution, of the C-suite, the CEO, the chief administrator, the head of pharmacy, the head of nursing, the different surgical departments, and even the provincial or even national authorities and bodies.
Yeah, no, I understand your pain, Prof. When we implemented at Grace, I went through most of the steps you pointed out on your flow diagram. The second thing is, when we implemented, we found that if we work with the laboratory service hand in hand to try and get us results faster, a more efficient way to determine how much of transfusion and stuff was required in patients, that we actually reduced our need for transfusions. So things like point of care was implemented in few of the wards, high cares, casualties. And what we showed that with training, implementing a good laboratory service, and trying to get buy-in with local guidelines, we were able to reduce our cost 5% every quarter.
Every quarter.
And just before I left Gray's Hospital, I think we were sitting about 70% of our patients only received 1 unit of blood, if ever. And I think Yvette Candy is online here, and she can verify the latest data on that. So it was looking good. And then with education, with all our interns, and we made it compulsory for them, they could not order blood, but it had to be senior doctors. And so we had accountability. And that made a huge difference in a public sector facility. And with retraining, we eventually got people to self-moderate and determine what was required and when they could use alternatives to blood transfusion. Another important point, Prof, and I want to know your comment on this. So you did mention 2.9 billion people with anemia and about 600 million with like chronic or acute blood loss, etc. But what we find is that we're not diagnosing many people with bleeding disorders, and all clinicians are doing is just topping them up with blood transfusions, etc., but not actually solving the problem. That's costing us a lot. Are you seeing that across the world as well?
Yeah. Let me talk about this, but let me also make one little statement regarding your cooperation with the lab services, because what you referred to is what I always call the low-hanging fruit in PBM. The very first thing is probably to look at transfusion numbers and make sure that the transfusion medicine or the department or the laboratory becomes the first gatekeeper, right? And really challenges each order of blood and says, well, why is that? And that leads now to your second question. And I make this very brazen statement that although blood transfusion is the most common invasive intervention in medicine overall in the world, it is the one that is usually done without a diagnosis. People are saying the patient needs a platelet transfusion, right? Or they are saying the patient needs a red cell transfusion. And when you ask them, well, why is that? You get answers like, well, don't you see that the patient is pale? Or haven't you read the hemoglobin or the hematocrit? But we all know it's not a diagnosis. And if you say, well, the patient is anemic, we also know it's not a diagnosis. What is the root cause of the anemia? What is the root cause of the bleeding disorder? And this is why PBM says our biggest problem, and this is again why we have to put this on the radar, or put it on the landscape. The three reasons for transfusion is unmanaged anemia and iron deficiency, poorly managed blood loss, and poorly understood coagulopathy. And so, as you said, a top up, right? It's a quick fix to change lab values, but it's a very poor service to the patient. We have exemptions. We have situations where probably all the options are possibly exploited, and then as a last resort, transfusions are given, sometimes with success, sometimes without, and we don't even know what is the mechanism that does it, right? Because there's a lot of evidence that it's probably not additional oxygen carrying capacity that's in the blood, in the stored blood. It is probably the only thing that transfusion does is a restoration of normal viscosity. That's probably all. But apart from this, you're absolutely right. What we have to do is good education on diagnosing and treating the A, B, and C problem, anemia, bloodless, and coagulopathy with bleeding.
Definitely. When we get consent for treating any medical problem, surgery, uh, cardiac failure, etc., we always have to explain to the patient in detail what's required in the process. And I think in our current medical curriculum, we don't empower our junior doctors enough to state the facts for blood transfusion. Things like how much of blood would you require to get iron overload? Or, or what's your risk for certain infections or an adverse reaction to it? All our doctors inform the patient is that you need the blood transfusion. There are some risks, but not too much. Please sign here. And I think if the patients have more information, more specifics, they would probably decline and ask for something alternative themselves.
Absolutely, absolutely, Jeglin. And I think you saw the in the aid model in the beginning, we have the quality and safety, the anchoring of PBM quality and safety, followed by the right education. And this is, empowering the junior doctors. And I think we should replace in each curriculum the section transfusion by patient blood management. Transfusion is one of many therapies, but where in the world do we start a medical process or a medical model with a therapy? We always should start with the problem and then see what options we have. And I think the mindset, this default position of treating A, B, and C insufficiently with blood needs to be changed in the roots, which means we have to reform the curricula when it comes to blood and blood management and patient blood management and blood health. This is something where we need to change the language, and with the language, the curricula.
Yes, true. Prof, there are some comments in the chat box. Yvette Candy, thank you for the informative talk. Please show the last slide with the QR code again. Max Lagarde, thank you very much, Prof. Rita Governor, thanks for the presentation. So many essential truths. Whilst waiting for policy to be implemented, I don't think she's finished that typing. Prof, okay. A quick one. When we
let me just show the QR code once more, because we're asking for, and just so here's the QR code again. Can you see it? Please make screenshots and then you. Is it okay? Can I go back to the other mode?
I think we're good, Prof.
Okay, good.
Prof, there is one question from Patience Lamini. How do we help clinicians stop defensive medicine? It's true most transfusions are done without a diagnosis. A lot of blood gets wasted, like you're opening a tap to a bucket with a hole, because one has to make a diagnosis, has not made a diagnosis. So how do you prevent that?
So good question, and part of the culture. Now remember my two slides with the EU regulation, right? Now we have the first time ever a regulation that legally obliges doctors to exploit every option prior to the use of substance of human origin. And this means if we really apply this medical legally, this is probably the first answer to defensive medicine in this context. Because imagine someone orders a 2-unit transfusion. The question immediately comes up, well, you gave him 2. You might have an indication for the first one, and please tell me what the indication is based on what diagnosis, and he might be already in trouble. But the second unit, you see, is definitely something that we have rarely, almost never, a justification. At least, given consecutively almost the same time. So there is a change in the mindset, and I think the education will also. If you look at for years, everybody was focused on what is called the direct. How do you call it? The direct impact or the direct hazard of transfusion, the ABO incompatibility, iron overload or volume overload. TACO, etc. But now with the large studies that we see these indirect hazards of transfusion that includes increased morbidity and mortality in a dose-response relationship. And this shows us that if somebody is really on the side of defensive medicine, then he must watch carefully how the paradigm is changing from pro-transfusion as a default position to pro-PBM as a default position. And I think this change is now happening. And we all know that defense medicine is anyway something very bad, but we can't eradicate it. But I think those who transfuse for the reason of defensive medicine are increasingly in the wrong corner.
Prof. Dr. Rita Govender has completed her comment. She said the PBM educational efforts can be directed to medical schools and public at large. I think that's a good comment.
Yes, yeah. I can only agree with Rita.
Prof, I don't see any further questions in the chat box. I think we've come to the end of this session. Prof, thank you so much for this wonderful talk. Can't wait to meet you at HemOnc. I have a few things I need to bounce off you, something that I'm trying to implement in Pietermaritzburg as well. Thanks to the speakers again. Thanks to Echo UNM and Echo India team. Recordings available on the GF website. Thanks to Gastro Foundation. Thanks to the sponsors. And I think next week it's lower endoscopy. Thanks again, Prof. Much appreciated. Enjoy your day.
Thank you very much. It was my pleasure. Have a good day. Have a good evening, everyone, and hope to see you in South Africa in September. No,
thank you so much, Axel, from my side as well. It was fantastic. Thank you, Jacqueline.
Thanks, Prof.
Thanks, everybody.
Axel. Thanks, Axel.
Thank you, everyone. Hi, Chris.
Nice
to
Hello,
see
Chris.
you.
Hi, Chris.
Thank you so much.
Great. Bye-bye.
Bye-bye.